This is Pill Talk with Dr. Bartu. I got a special guest, a good friend of mine. Went to pharmacy school together, Dr. Jimmy Pruitt, ER pharmacist at two different hospitals, co-founder of PharmSoHard Podcast that's out on multiple platforms right now, and also the founder of Friday Pharmacy Pearls, which started in one hospital and is right now in 18. So no introductions needed. Mr. Dr. Jimmy Pruitt, how you doing today?
Thank you, man. Thank you for the introduction. I'm doing well. Thank you for having me on. I think it's going to be a pretty cool episode, and thank you for creating this new platform for us.
Hey, no problem. So, like I said, we went to pharmacy school together in Presbyterian College School of Pharmacy in Clinton, South Carolina. But currently you're based out of Georgia, working at two different hospitals, being an emergency pharmacist. So first, we want to talk about what's the steps to becoming a emergency pharmacist inside of a hospital.
Perfect. Yeah. So for now, this is a relatively new field. It's been having a huge expansion over the last few years. So what it has been, the training for it before, the role was more of a med history and things of that nature, but now we're moving towards more specialists. So now you have your pharmacy school, and PGY1 training and residency was a key thing, but now we've had such a huge explosion of ED pharmacy, in particular the specialists being there. We've went from residency programs being like around 4 to 5 in the mid 2000s. Now there's over 70 programs. So now more pharmacists are getting PGY2 trained in emergency medicine. And a lot of people are also still getting trained in critical care and then just revert over to emergency medicine. So again, for the most part, you have your pharmacy school, you have your PGY1 training, but now more and more people are getting PGY2 trained.
That's good. You talked about PGY1, PGY2 residencies. Most people don't understand or don't know that pharmacists goes to residencies to get more clinical and more knowledge base in a particular field. Can you describe or talk about the residency process a little bit?
Yeah, it's very tough. And I think I try to talk to my medical doctors about what the process they go through. And we basically go through the same platform as far as going through a MAT process, which traditionally starts in December, where most of us will go to the pharmacy annual meeting mid-year. And then from that standpoint, we can do this PPS interviewing, which is basically speed dating for residency programs. You would go, you have 10 to 15 or 10 to 30 minutes to talk to the residency program and the current resident, and to get a feel for those individuals. And then after that meeting is over, you submit your application along with hundreds and potentially thousands of dollars to submit your residency application. And then around January, you go through and you receive your rejections or your exceptions for an on-site interview. And this year is probably a little different because of COVID. So we may not have as many on-site interviews, but you will have just more of an official interview. Once from there, you submit your rank listing by the end of February. We're getting the first week of March. And then I believe it's usually the second or third Friday of March where we have match day. And you basically go through a system. It's like a lottery system of placing you, the candidate, with your top program and matching the candidate's top residents as well. So it's a weird algorithm that goes into it that I think no one really knows, but they try to match you with your top people. And then once you get there, it's just your cheap labor. You're learning, and it's challenging, but you're rotating through. And this is not, we're on the floors. We're rounding with the physicians. We're rounding with the nurses. Where I did my training at, I would actually be on the floor for almost majority of my shift. Again, I'll work primarily with the physicians and the nurses to make sure the medications are correct and just go through the evidence, teach, and just do all the things that a clinical specialist would do. And then PGY2 training, same process over. Unlike for medical residents where they have one program they match with, complete all of their training, if you receive second year training, you can go to a different program if you don't early commit to the program you're currently at. Same process, same PPS interview, same process to where you match for a program and you spend 1 year there. So I like to say that our residency is similar to doing like internal medicine for a physician, and then going and specializing in the fellowship is what our second year will be equivalent to.
Oh, that's good. That's good. That's a lot of work, a lot of knowledge, a lot of work-life balance that you got to balance out there. So you're ER pharmacist. Tell us exactly the description of your job description. What do you do in the ER to assist the physicians, to assist the nurses, to make sure that everything in the ER goes great?
I can tell you what I don't do. I don't count pills very quickly in the nursing department. But more particularly, what I like to do is a lot of what we do is creating pharmacy care plans and basically doing it at the bedside. And I'm not sitting down writing these things out. So, for example, we have a patient that comes in any medical emergency, I'll respond to along with the team. And any medication that is being asked for, I like to say that we're 5 to 10 minutes ahead of that. So we assess the patient based off the training that we have and alongside with the work of our colleagues there, and we're able to, facilitate those medications. Now, what I mean by that is knowing where that medication is from the beginning. So having the Omnicell, or having some type of automatic dispensing cabinet, and you being responsible for placing those medications in there from the beginning and organizing that, being to get those medications, draw them appropriately, dose them appropriately, and making sure that there's no interactions, because in the emergency department, we're not going to go assess the patient, go put an order in, come back to the bedside, and go through the process that is traditionally done for most areas of the hospital. Usually the physician looks over and say, hey, I want this particular medication. And as a pharmacist, you have a quick second to be able to basically verbally approve that order or say, hey, how about this? How can we change it to this dose or change it to this medication? And once we get the medication, draw it up, dose it, label it. For my nursing colleagues, we make sure that what access do you have? Because if you have a peripheral access compared to a central line, you can give certain medications as quick or not. So understanding how quickly you can give a medication, compatibility issues, and learning how to monitor that patient after. What are the adverse effects that can occur, and how do you mitigate those? So all of that is just in a one patient. And then outside of just being at the bedside, the more administrative component of that, what I mentioned before as Omnicell optimization, making sure you have the medications in the correct area, order verification for those patients who are not more critical, that they're actually putting those medications in, and answering drug information questions. I probably get anywhere from 20 to 30 drug information questions per day, particularly which antibiotics to use for this particular type of infection. What dose, what route, can I give it IM? I don't have IV access. What's the alternative PO version of this? And understanding how to create a plan for a patient. And usually how that goes is I ask where the patient is going to go. What's the dispo for the patient? Are you going home? I have a plan for you. Are you going to the ICU? I have a plan for you. And if you're not, if you're trying to avoid using the higher levels of care, I have a plan for you, because depending on what my plan is, I can change the medications to better suit that patient. So I see a lot of information what I did, but how I explain this to the lay public is I make it go from brain to vein. I take what's in the physician's brain and I put it into the patient's bloodstream. And I do that in the most effective, the safest, and most cost-efficient way that can help not only just the patient at that time, but it actually helps the entire hospital system. So when I make a recommendation, I'm thinking about all those things and knowing how to carry that out. So taking each step from the physician's brain, from what he assessed, all the way to the patient. So that's my role as a medication influencer, I would like to say, as we are in the emergency department.
That's dope. That's dope. That's a lot of quick thinking on your feet there. And speaking of that quick thinking on your feet, because it's the ER, it's 100,000 different cases that come in a day. So are most of these cases so similar that you already have a plan or a process in where you can already be like, okay, we know this person coming in with these symptoms, so we should go ahead and follow this algorithm or this chart? And do you help make that as well?
Absolutely. So one of the other components of that is knowing just certain disease states, and it's a certain variety of disease states that we will see more frequently than other specialties. If a patient comes in with heart failure, usually we see those patients, but we see them in acute exacerbation, and understanding the 4 different subsets of that and having a plan for that. So you mentioned that, how do you help create those pathways? a lot of what I do outside of the bedside is creating order sets, creating algorithms and guidelines. So our physician and nursing colleagues weigh on us heavily to create these things and have them in process. So if a patient comes in, I know based off what we have agreed to that they were going to get, ABC medications at this particular dose, this particular route, and training the team through education and creating the order sets and giving a foundation, so to say, hey, if a patient comes in with a COPD exacerbation, these are the medications we have here, these are the doses we should use, and this is what the evidence say we should be doing from a pharmacy standpoint. So you create this blueprint for the average patient, and then if something needs to be modified or changed, having them consult us to see it's a slight difference to this patient, how can we help them in this particular case? So that's something that we do quite often, and one of the things that I think is key to being a ED pharmacist, being able to understand that most patients can fit in certain aspects, but then learning how to make a particular recommendation that's specific and unique for a particular patient. So just creating the foundation and then being available and studying and understanding that your training can build you up to a point to where you understand that not every patient is the same and how to treat those unique and special situations.
That's good. That's good. Yeah. So you make sure you got the quick decisions at the bedside. You help formulating guidelines. Mentioned earlier in the introduction that you work at 2 different hospitals in the ED department. Are the guidelines similar or different because, different locations will have different type of patients?
Absolutely. That happens quite frequently. I work 2 hours away from my 2 different shops, and it's interesting how different those institutions are in their patient populations, but how similar some of the cases arise. One example that I have is I was fortunate to create a same protocol for the same patient population, and we did slightly different things based off my physician weigh-in and what the guidelines and medication safety administrators had to say about that. So for a patient that came in with pulmonary edema that was secondary to acute heart failure, we use high-dose nitroglycerin. And at one of my institutions, we would use a bolus dosing of nitroglycerin at very high rates, at like 1 to 2 milligrams. I take that, but in my second institution, they don't want boluses at all. So to compound, make sure that it was a difference, but similar efficacy, we made it to it as an infusion at a higher rate, but given at 400 mics per minute over 5 minutes would meet the 1 milligram bolus that we would give every 5 minutes. So we have similar patients, similar to say that came in, but you can be the same patient to go to 2 different institutions and receive a medication slightly different based off the protocol that was made and based off having evidence to do things 2 different ways. And emergency medicine is one of those areas where there's not a lot of black and white. It's not just this or that. It's a lot of gray area. And I think one of the key things to being in that field, and one of the most frustrating things for pharmacists that come from different areas, is understanding how to navigate that gray area to fit your team at that particular time.
Okay. That's good. That's dope. So speaking of you working at 2 different pharmacies, and we spoke a little bit about creating guidelines. Let's step into the Pharmacy Friday Pearls. Can you speak about that and how you incorporate that into your workflow?
Absolutely. So Pharmacy Friday Pearls was just originated due to me wanting to engage my physician and nursing colleagues in a manner that didn't take up all their time at the bedside. There are many times where I would say, hey, it's a reason I want to do this, and this is the best thing for the patient right now, but I don't have time to explain it in the detail that is necessary. So after a period of time, I realized, I said, hey, if I had a few moments to have a time period to talk to individuals at a set time every day about key pearls that would come up, this would be more beneficial and help us at the bedside. And this started out as being just something I did for like a couple minutes on a physician changeover. And I started sending out as an email. And then from there, I created a website for it to house all of the handouts that I would have. And then I record certain videos and YouTube videos and house all of it there to explain in more detail the things that our physician and nursing and pharmacy colleagues want to learn about. And what it has become now is an avenue for me to educate my team, and in a manner that's not necessarily always at the bedside. And what I found was that it made it so much easier to give recommendations, because they would say, oh, that was that email you sent out last week. This is why you want to use Versed versus this, or this is why you want to use ketamine at this dose. Now I understand. Because one of the aspects that we get involved in, especially within hospitalizations of patients, is that we stick to what we know all the time. We don't want to change up, even if the evidence doesn't support that. And providing evidence and providing the foundation from a pharmacology standpoint, and then also very briefly summarizing data so our physician colleagues and nursing colleagues can understand why we're doing it, has led to a very unique and evidence-based practice. This is something that I promote to all institutions. And this is why it's now been sent out to various hospitals throughout the nation, because I believe that while we have very unique and different institutions, certain cases are similar enough to where if I provide you the information, you can modify that best fit you. And I've been very happy with the Pharmacy Friday Pearls. And usually I'm doing this outside of work, or I spend some period of time in my office hours creating these handouts and updating the website. And that's something, that's probably how I work it into my workflow. But when I was a resident, when I first started this, I would just do it at home. I would just knock it out and spend the hours it needed interpreting information, data collecting, and creating a platform to disperse this information. It was just key for a lot of success I've had early in my career. And I think it's something that I hope to continue. It's something now that's part of the PGY2 requirements for where I completed my residency. So it's been phenomenal. It's a good bit of work. And now I'm getting able to spread some of this workload out to the residents and other pharmacists that want to collaborate. And it's been phenomenal and less work for me, but still providing the same foundation and structure to provide education to people in the emergency department in critical care.
Man, that's great how something started so small and is going all over the place. So I got two questions. One is, what kind of topics that you put inside these Pharmacy Pearls on Fridays, the Pharmacy Friday Pearls? And question number two, how can someone get access to it?
Perfect. So the type of topics usually are, I pick it based off the cases I've seen over the week. So if there was something that was unique, or there was something that was a controversial topic, so again, we spoke about using high dose nitroglycerin in patients. We're used to giving sublingual tablets. They have chest pain, but we're not used to giving 3 to 4 tablets worth in an IV formulation. And people felt uncomfortable about that. So I created that topic. Another thing that came up was the use of things like hypertonic saline, which is, very high risk medication. So that's how I picked the topics, based off just how unique and how uncomfortable people feel about that particular topic. And usually they're going to be focused on acute management of patients for some type of exacerbation. So again, cardiac arrest, COPD exacerbation. So the things that bring patients in and are in the sickest periods of time in their hospitalization, those are the topics that I spend the majority of my time on, because again, those are the ones that are exciting. Those are the things that people want to talk about. And those are the things that, interesting enough, don't have as strong data for the things that we do. So just being able to analyze that stuff and put it in a concise form, that's back and forth. So for your second part of the question is how to access those. So my website is called Pharmacy Friday Pearls, and you can go at pharmacyfriday.com. It'll send you to my Google site. Now, again, it was something that was small, and we're fortunate enough now within the next month and a half, we're going to transition from my Google site to a different, more revamped website that's going to house a little bit more information and have more features that can help you go there. So once you do, you will have access to a few different things. So each topic will have pre-questions, because this is part of the medical residency program where they can actually get credit for participating in a module. So each module will have a pre-test and a post-test, and then you will have the handout that's available for download if you just click that button there. And then I also have an area where you have related information. So if you don't like my stuff and you think my stuff is trash, you can go to get other smarter people's material. So all of that's going to be found at pharmacyfriday.com. And again, moving forward, we're going to keep the same link, but we're going to change over to a different host to that website to make it a little bit more engaging for our audience and be able to add more features that can help us out. And by the end of this year, we're actually going to be pushing out an app. So that's going to be where we can house a lot of information that's more quickly really available for Android and for Apple users.
Man, that's amazing right there. That's amazing. People, please go check out the website and find out some good information on these pearls, take the pre and post test, see what you know. You know what I'm saying? Also, I want to know, it seems like you got a lot going on. 2 different pharmacies, 2 different hospitals. You're doing the pearls every Friday. How's the work-life balance going?
I think everyone, that's a question I get all the time. I have a family, and I'm pretty engaged in working out and staying fit is something that I play. I would say for the most part it's challenging at times because I thrive off passion. I thrive off a purpose, and for me, doing these activities, being at the bedside, going and having a diverse working population, it gives me purpose. So I feel that I get to the point to where I take, plant breaks every often, and I work most of my shifts in bulk. So I recently changed from a 7-on, 7-off model to more of a 4-on, couple of days off, and then 4-on again, to where I can work the majority of my shifts at both institutions in a period of time where I just knock out a few days there. Then I have a long period of time off that I can complete some of these tasks, or I can delegate some of those tasks to other individuals who's interested. And then I can focus primarily on just relaxing, spending more time with family. And whenever COVID decides to, get itself, out of here, I can get to traveling, which is something that I've been really wanting to do over the last few years. But residency and my first year out and just throwing myself into my passion has led me to spend most of my time at my office and at the hospital. So it's something that I'm definitely working on. My colleagues always joke with me about and say, "Do you ever sleep?" And I say, "I sleep 8 hours, 8 hours, but when I'm up, I'm going." And it's just that's something that works for me. And I know that as I progress in my career and as I get other administrative tasks, that I'm gonna have to do more delegating of certain tasks and work a lot less. And I think that as I advance in my career, I'll probably get to a place where I have just one job in one location and being able to delegate more of these tasks. But right now it's just building the foundation, building a brand. And as that becomes to be built and established and I can trust other people with something that I love, like I love this stuff. Like it wakes me up every morning. So once that's available, then I can kind of take a step back and focus more administratively and move to working a lot less and doing other things outside of pharmacy and following some of those passions as well.
Yeah, man, I can hear it in your voice. You're talking with passion. You know what I'm saying? That you love this and you really want to be there. So going to work for you isn't going to work. It's going to the place that you want to make a difference. You know what I'm saying? Like you said, you're building your brand. And speaking about your brand, let's talk about your podcast, PharmSoHard Podcast. How did you come up with the idea? You're a co-host and co-founder. So let's talk about how you came up with it. What are you presenting with this podcast? What information are you giving out to other pharmacists and other people in the medical field?
Perfect. Yeah. So PharmSoHard came after when I was in my first year of residency. We would sit around and we would have topic discussions all the time, and the structure was just so rigid, and it seemed like every time we would talk about something, I felt like just how I was raised in the environment I came from. Sometimes it's better to talk about things in a more relaxed environment, or just being able to use metaphors to help me understand a little bit better. And I realized, like, man, this is horrible. I hated doing this. And a few of my co-residents was like, "Hey, man, how about this? Let's all get little topics that we know a little bit about, and let's go out for drinks after, and we have 5 minutes to have a conversation about this." And this was inspired by one of my preceptors, BB, who works at Florida Hospital Orlando, well, Advent Health now. And he would talk to us in a manner that I was like, man, I really get this. And at first we just called him BB Talks, to where he can just talk to us about something that was more relaxed. I was like, man, I really like to record this, just because it gave me so much energy and it helped me apply to the patients a lot better. And my co-host and co-founder, Oscar Santalo, he was the administration resident, and he was very good at like putting things together, being able to be great with like audio and editing and doing things in the program. And I thought to myself, like, man, what if we just came together and used our big personalities and made a podcast? And we talked about it for a while, and just due to the nature of residency training, didn't have the time to do it. And finally, once we both got done, we just sat down and put everything together. And we was like, if we do this, you can talk about the administration process or being like a pharmacy manager, and, operations manager and understanding that part of institutional pharmacy. And I can talk about my experience from emergency medicine and like critical care side of things. And we can have a huge audience base to where we can have other individuals come on and talk about a particular topic and really just tell them, hey, just imagine you're out with your buddies and you're talking about something and it's more of a relaxed environment. We can joke around. It's not so rigid. And when I looked out there from at the time, podcast for pharmacy, which just wasn't, we didn't have those things that were just relaxed. It wasn't just chill. And we definitely didn't have a diversity within that. There wasn't many people that looked like me that was, speaking. It wasn't people playing, hip hop themed music in their intro. It wasn't people doing that before. And I thought to myself, this would be a great opportunity to engage a different audience. We know that pharmacy is changing. We know that other professions are changing and they want to hear things in a different manner. And once we got together, we've been fortunate. We've just released our 25th episode, and we haven't been a year yet. And we've had people from all the way from Seattle to New York, some of the heavy hitters and people who have lots of letters after their name within pharmacy come and speak on the show and give their expertise. And I just like to say that from my standpoint, I'm just a fan talking to my heroes of pharmacy about topics that are important, like residency training, like, transitioning from being a student to a resident, and also transition from being a resident to being a practitioner. And once we get these conversations going, it's just kind of a chill environment. We sit back and forth, we chop it up, and it's just a nice vibe. You come on, you hear an intro, and then you can hear, when we leave out some music that you've been listening to on the radio, that you're blasting your headphones at the gym. And I think it's just something that we can engage a huge audience, because we talk about many different things, from half of it being administration, half of it being emergency medicine, or just general pharmacy topics. And I think that as we continue to grow, we're going to add additional components to that, where you don't have to work in the ED, you don't have to work hospital, but the topics that we're talking about can be relatable for all pharmacists, and even all practitioners, because pharmacy is in everything. Every physician, every nurse, everyone do it. And I always end my episodes where I tell them, you don't have to be a pharmacist, you don't have to work in the ED, but everything you do, make sure you farm so hard. And what that means is just anything that has any medication to do with it, just go hard at it. Know this information, know where to find this information, be educated, and be able to provide, go from brain to vein, and make sure your patient is getting the best experience possible.
Man, I really like the fact that how you said, like, you went from having those discussions being rigid to more relaxed, because the profession is changing. It's a whole new generation coming in. We're younger. We want to be more, we want to go to work and be able to have conversations with people, not as a supervisor to someone under them, but more of a friend to friend or colleague, because you want to go be able to get to work and enjoy work. So making it more relaxed, even in the podcast, will also lead to making it more relaxed at the workplace. So that's a great idea that people need to, everything doesn't have to be super intense to get the knowledge out there.
It doesn't have to be boring. I listen to certain things, I'm like, man, I can't listen to this guy talk anymore. This guy's boring. Like, he's, hi, my name is this and that. Like, I can't do this, man. You got to throw some foreign drip on there and get it going, man.
Hey, you already know. So how often do this podcast come out?
We try to make sure we release every 2 weeks. We just took a break in August just to get some away time and work on work-life balance. Yeah. And so most of the time we'll release a double episode. Like, we release one episode that's administration, then we release one episode that's more ED, critical care, hospital, clinical pharmacy related. And so we try to get it out at least a couple episodes at that point. We also have some shorter, like, nuggets and pearls, where I'll take some of the Pharmacy Friday pearls, record something real quick, and release it on this avenue to kind of have a double release. We also partner with a few other podcasts to do double release on theirs as well. So every 2 weeks is what we traditionally would do. Sometimes we'll space it out and drop, three episodes in a week, but we average around a couple episodes every 2 weeks.
Man, that's dope. I like the fact that you went back and using your Friday Pharmacy Pearls, making it a nugget and putting it into your podcast. So that way they catch it on both ends. They couldn't catch the Friday Pearl, and they could catch the podcast and like, oh, this is what I missed over here. Appreciate it. That's really smart right there.
Because everyone like learns and hear things differently. Sometimes you want to see a handout front and back and be done with it. Other times you're driving to work and you have 10, 15 minutes. You want to pop something in. It's like, I read that handout, but it didn't stick with me. Now it's like, oh, I get it now. You can put a patient case to that. You can put a little bit more information to it. So for example, the last 3 Pharmacy Friday Pearls has been on different things for acute agitation. And then our episode we dropped yesterday was on all 3 of those, and we just talked about the entire aspect of how to manage patients with acute agitation. So I think it's cool to where we can make it small enough and little nuggets for people for each Friday. But then if you have 20 minutes, 20, 30 minutes, and you want to hear how all of that matches together and have a complete and comprehensive review of something, then we can go on with that. I have one of my physicians, Dan, that was on there. He talked about the assessment of the patient and what he's thinking. And then he asked me, hey, from a pharmacy standpoint, what are you thinking? So now you can get the data, you can get a physician's thought process, you can get a pharmacist process, and then put it together. And that's how you farm so hard, is being able to combine a lot of information together to best take care of your team and your patient.
Smart. There's some great stuff right there. How can people find this podcast and give it a listen?
Perfect. So we're available on all the major platforms. Go to Apple Podcasts, just type in PharmSoHard, Spotify, Stitcher, and then you can go to pharmsohard.com and you can find all those avenues to where you can get it on your phone. If you go to the website, again, we have a lot of the show notes that are there, the studies that we talk about, and any algorithms that we've created and talked about, guidelines. We have all that information in one spot. So you can have a one-stop shop. And then if there's any other podcasts that are similar to that, I've linked those in the show notes as well. So you can have, again, more comprehensive view. We're trying to make sure that we have people get the knowledge they want to for free, for cheap, and just get it to where it's available. So that's our vibe, and that's how we're going to continue to rock.
Listen, the one-click stop right there. You go there and get with everything you need. You know what I'm saying?
Absolutely.
One more thing. So with COVID, you mentioned COVID earlier, working in the ED, a lot of COVID patients. How has that changed the way that you move and work inside of the hospital currently?
Yeah, man, it's been crazy. From the entire start of it, the ED pharmacists were the only ones that were still on the unit, because I can't do my job, effectively, I would say, from distance and from home. So when it comes to PPE and make sure you're having all your gear on, I go to work with, N95s, face masks, head shield. As far as just my equipment is changed, and I'm wearing these things all day. I think it's interesting, and people get frustrated from wearing a mask when they go out and stuff. I'm wearing these things, full gear, for 11, 13, 14 hours a day. And as far as the involvement I have, beforehand, I would be basically any sick patient in the emergency department. I was in the room looking at the patient, getting an assessment, asking questions, getting medication histories, doing those things. That's changed now. A lot of that stuff happens. We have a brief second to get in the room and look at the patient. But for the most part, for cardiac arrest, I'm used to being in the room doing my thing. They've moved the code card outside. So now we're passing meds in. As far as it's just a lot of processes and protocols has been modified to make sure we're wasting medication appropriately. If you have a patient that's COVID positive, we have to waste that medication now because we can't bring it outside the room anymore, because we just don't want to contaminate people. So I think just how I move has been different, being more cautious. Again, one of the things that I pride myself on is being a team player, but sometimes some of the non-pharmacy tasks that I would do, put a patient on a monitor, do CPR, listen for breath sounds after intubation, like all these non-pharmacy things that is helpful but not necessary. You have to cut some of those things out to make sure that you're taking on the role of understanding how to manage these medications, not just from a clinical standpoint, but just from just being clean, like what goes in, what goes out, and how to monitor these patients, because COVID presents a different subset of patient. They respond differently to sedation. They respond differently to the therapies that we provide, acutely. So it's just understanding a different patient subset, understanding different processes and protocols that are occurring, and just the equipment, and just dealing with the emotional part of COVID. Most people don't talk about that. Our nurses and our physician colleagues are struggle mentally with this, because you don't just go to work and come home and everything's fine. Yeah. You gotta take all your clothes off outside of your home and wash them and sterilize them before going in. There are some people who are not seeing their spouses and seeing their families because, when we had our highest peak of COVID, we know we were seeing 5, 6, 10 patients per day that had COVID, and that has changed. Families are being, sent to stay with their grandparents and mother-in-laws, things of that nature, just to prevent the exposure. And it's taken a mental drain. So I think it's not necessarily work-related, but I think understanding the emotional component of that, what people are going through, and then the politicizing of everything that we're doing with COVID, people thinking that it's real, it's not real, the medications work, they don't work, and the emotional toll that this is taking on the staff and is taking on just all of us in general has been challenging. And I think being supportive of the colleagues has been another component that we've had to step up recently, because it's been a long time. This has been going on for a while, and everyone's tired of it. And we don't have more PPE. We don't have super effective drugs, even though we say we have these magic bullets. The evidence just doesn't always pan out. And just dealing with the questions, because sometimes you have medical professionals who are very involved in politics, and that the evidence that comes with certain things are sometimes, jaded. Sometimes the information is shaded to fit one party versus the other. And I can care less whether you're left or right or up or down. I just want to take care of my patient. And sometimes you have to answer questions that are due to the media and due to, politics, and all of that has been challenging alongside with everything else that's going on in the world right now.
Man, you said a couple great things in there that I want to touch on a little more. Number one is like the emotional drain. I'm a retail pharmacist, work at a big chain, and having to do this every day. When you came in here, you said you guys are bonding with your colleagues, and you guys have to go home and script down and sanitize and everything before you go in the house. How are you doing with this right now?
Yeah, personally, it's challenging. When I everything that I always have a separate pair of clothing that I have with me that we can swap out before getting in, because I don't want to expose my family to something. Washing your clothes every day, that's a different vibe. Again, everyone has their thing. That's every time I come home, my uniform goes in a wash and dryer. It gets sprayed down, wash and dryer every single day. So that's challenging. And then emotionally understanding that only thing I've been fortunate to grow up in tough times, grow up in tough environments, to where a lot of the coping mechanisms and the strategies I've had growing up, not having a lot, seeing a lot of difficult things, being in very difficult situations, has helped me stay strong in times now where you say, well, I've dealt with hard things before, I can deal with this now. And it just reminds me of, living in poverty. You can't go nowhere. You're stuck in, you don't have the resources to go places. The economy is bad. For me, this is just, people say COVID is ghetto, but this is really what it feels like in my head. You can't do the things you want to do. You're limited resources, and you have to be extra cautious of everything you do. This reminds me of living in a bad environment. And I think that having that experience before, having people who I grew up with, who's doing well, who's going through the same thing, and bonding with them, has led to me being able to say, I can do this. And I've always been a team player. I played sports growing up. And for me, this is just another, team sport that you go in and you compete every day. And to get the dub is to get out of there mentally intact and your patient taken care of. And that's how I go to work for my teammates. I push hard for my teammates, and that's what wakes me up. That's what keeps me going. And that's what's been the bright side of this. For every struggle, there's something that's just beautiful to come out of it. I've been able to bond with people who I didn't think I could bond with before. And I've been able to accomplish some things that I didn't think I could before, simply due to the fact that we're all just trying to get through.
That's dope. That's dope. Because you're in there dealing with these COVID patients on a daily or regularly, how often do you guys get tested? Or how often do the hospital give testing to all the staff and employees?
So that's the challenging part now. Again, we're not required to get testing if we don't have any symptoms, anything like that. So we're getting monitored for fever every day. So you can't get to the hospital without getting a questionnaire and getting your fever, your temperature checked.
Yes.
Again, if you don't have those, again, depending on which revision of the CDC guideline that's released, you don't necessarily have to be checked. Again, if you had an exposure to where you have been without your equipment, you've been out without protection, it's available for us, and it's available for us at no charge. So we have easily accessible from that standpoint data, but it's not required, and we can get it done frequently. This hasn't been a situation that's come up for me personally yet, because we've, even just from a pharmacy department, has taken steps to minimize exposure directly with those patients. I have, me or my colleagues that I've had at most of my institutions have not had any issues, but again, for those that have, they've been tested, they've had to do their quarantine, and we haven't had any major health issues from this particular thing at this point.
Oh man, that's some good stuff. So Dr. Pruitt, let everybody know how they can get in contact with you, your hashtags on Instagram, YouTube, your podcast, your websites, to make sure that anyone who wants to get to get a Friday Pearl, Pharmacy Friday Pearl, they can go there. Anyone who wants to listen to the podcast, they can get there. If they want to follow you on Instagram, drop your IG handle.
Perfect. So again, you can reach me, my public email that I let people, you can go to pharmsohard2019@gmail.com. So if you need to get in contact with me about any pharmacy information, or want to get in contact about the podcast, you can go there. Pharmacy Friday Pearls, again, is at pharmacyfriday.com. You can go there and you can see everything. I have contact information there as well. The website for the podcast, pharmsohard.com. And then I'm really active on Twitter at PharmD _ and then ED. You can definitely reach me there. And then for Instagram, I'm just Jimmy Lee Pruitt, just my full name. It's easy to find me there. So I like to joke around with students and residents. I'm probably the most accessible, ED pharmacist in the nation, because of just all this stuff that we have out there. So definitely reach out to me there. I try to get back as soon as possible, but I'm really active on Twitter, especially for our pharmacy topics and being able to get in contact with me from that standpoint.
That's dope. That's dope. This was Pill Talk with Dr. Bartu. I got my merch on Amazon. Click that. You can find me on IG at Dr. Bartu. That's it. Thank you guys.
No, thank you.
Appreciate you, Jimmy.